All right, looks like we have people here. Just remember, if you're going to speak, just please unmute yourself, as you are all muted right now. Thank you and welcome.
Great, thanks, Aaron. Hi, everybody, and welcome. Good afternoon or good morning, depending on where you're joining us from. This is Cicely McWayne from SAMHSA, and I'm so excited that we have over 41 of our states and the District of Columbia sending folks in to join us for this really important topic today. We're going to be focusing on overcoming barriers in supporting suicide prevention conversations with service members, veterans, and their families. And on behalf of the administration here at SAMHSA and our partners at VA, who you'll hear from in just a moment, thank you again for deciding to spend the next hour and a half or so with us on this important topic. You can see that we're joined today by our partners in the Governors and Mayors Challenge efforts. If we can go to the next slide. And I wanted to just give a moment for Dr. Edgar Villarreal to say hello from the VA side of the house. Edgar?
Yeah, good morning, good afternoon, wherever you're joining us from. Thanks again for having us and for representing your state teams and the great work that you're already doing in this partnership that we have to address veteran suicide. Really excited to have Dr. Mohat with us today, really addressing a very important issue that I think a lot of states run into as we work to think critically on how we implement some of these interventions with our states. So again, on behalf of our National Program Office of Mental Health and Suicide Prevention, we appreciate your commitment to this initiative. And if there's anything that we can do on our end to support your efforts, please don't hesitate to let us know.
Thank you so much, Edgar, for that warm welcome. We'll be spending some time together in this virtual environment, and there's a few logistical components we'll go over quickly. One, please know that so many of your colleagues and all of us can come back to revisit this material. The recording of this session will be live today, and we will be asking folks if you have any reasons that you're not comfortable with participating in the session today for that reason, that you can go ahead and disconnect. We will be having all lines muted unless they are speaking and presenting, and so we're asking folks to use the chat box today for submitting questions, which some of you have already done, and we appreciate that very much. Additionally, if you have any issues with technology, we have a number of the TA Center staff standing by. In addition to the fact that we're joined by Donna Alagata, the Senior Advisor from SAMHSA's SMVF TA Center, who's going to be moderating for us today. So again, as we get more and more folks joined and logged in today, welcome. And let's go to the next slide if we could. And I have the honor of introducing Dr. Nate Mohat. As you can see here from his title, it's quite a lengthy one, but if I could just share a little bit about Nate's background. Many of you may feel that he's a familiar face if you've come to any of our Policy Academy events or conferences over the last few years, because he has been a regular part of our cadre, our leadership team from the VA side of the house to help bring this really important information to us. And he actually serves as a community psychologist who has a number of years of experience working with both rural, indigenous, and military and veteran communities. His areas of expertise, as you'll hear a bit about those today, are developing community-based suicide prevention programs, empowering and helping to bring about participatory research methods that reduce health disparities, and cross-cultural considerations for suicide prevention. Dr. Mohat holds appointments as a research psychologist with the VA's Rocky Mountain Mental Illness Research Education and Clinical Center, known as the MIREC, and an assistant professor of physical medicine and rehabilitation at the University of Colorado, Denver School of Medicine, as well as a clinical instructor at in psychiatry at the Yale School of Medicine Division of Prevention and Community Research. He additionally serves as a subject matter expert in psychological health and prevention for the Department of Defense Military Operational Medicine Research Program. So you can see many of our federal partners and others turn to Nate, given his amount of expertise and knowledge in so many sections when it comes to suicide prevention and working with our communities. Many of you may know him as well because he helps to lead some of the work with Together with Veterans that a number of our state and Mayor's Challenge teams have been involved with. So today's conversation is just that. Nate's going to guide you through a number of slides that really content-wise are going to be giving you these key gems of information that he's learned through these years of work with both communities and the experts in the fields when it comes to suicide prevention. We do want, as much as possible, although you're muted, for folks to take a moment and really look at how they're going to be able to give those questions a thought. How is this information applicable to you and the work that you're doing in your communities? We want folks to definitely be aware that these questions, even if we can't get to all of them today, will be something that Nate's been generous enough to give us time to help glean this information, and we'll get back to you on. So as much as possible, we hope that you enjoy this time and are able to really participate in the conversation with us. That said, I'm going to hand things over to our wonderful colleague, Dr. Nate Mohat. Thanks again, Nate.
Thank you so much for that introduction, and I'm really excited to talk to you all today. If we could go to the next slide, please. Yep, please be sure to mute your phones, I guess. Okay, next slide, please. And wow, really great to see so many people from all over the country joining us, and looking forward to having a discussion with you on this topic. So next slide. All right, so what I am presenting today, these are my views, opinions, etc. Much of this that I am presenting has been funded by the Department of Veteran Affairs, but they do represent my views, not those of the VA or the US government. Next slide, please. So the slide deck that I'm going to be talking about today and presenting off of is looking specifically at sociocultural barriers to help seeking in rural communities. That said, I do want to sort of pause here for a moment and just let you know that I am going to be speaking more broadly than just to rural contexts. The barriers to help seeking that I'm going to be talking about are critical across contexts, across cultures, across different types of communities. And as you will see, some of these barriers are just heightened in rural communities. So I'll be talking about that. And really where the rural will primarily come in today is I'm going to talk about our program Together with Veterans, which is a rural suicide prevention program. And I will be talking about Together with Veterans today more as an example of how you can structure conversations with service members, veterans, and families, and intervene in community systems to help reduce these barriers to help seeking. So next slide, please. I already said this, so next slide, please. Okay, so if we're talking about suicide prevention in a community context, one of the first places I want to start everybody thinking about this is, what is a community? What do we mean by that? If we're going to intervene in our community, what do we mean by that? And so this is the CDC's definition, and you can see that it's fairly standard definition of the idea of people living together, often in a defined area physically, but sharing culture, values, and norms. More broadly, though, we can just sort of really sum this definition up as a community is a group of people who share something in common. And so while a community can be a town or a county or a state or a country, it can also be your work site, your school. It can be your peer community. It could be the community of veterans. It could be the community of women. It can be defined culturally, etc. So what that means, though, when we think about community defined that broadly, is that people actually belong to many different communities simultaneously. No one belongs to only one community. And these communities that we belong to have a lot of influences on our health behaviors. And so if we are targeting an intervention towards a particular population, we want to think about the various types of communities that are influencing their choices and behaviors around suicide and suicide prevention. And we have to collaborate across these different types of communities to really create that kind of change that might really shift, broadly speaking, at a whole population level, the health behaviors of service members, veterans, and their families. Next slide, please. So we've probably all at some point heard about social ecology and the social ecological model for human health. This is another slide representing that, but the really big point here is that those behaviors, those choices we make for our health are embedded within these multiple communities that I just talked about, and these multiple communities at different layers and levels. So we have community systems in terms of the places that we live, and those can really influence what we have access to and what we choose to access. Likewise, there are institutional systems embedded within those locations that we live in. So the healthcare systems, the education systems, the law enforcement and justice systems, all of those are also a layer of networks and systems that we access and use on a daily basis. And how they're structured and what's available in those systems is going to have an impact on how healthy we as individuals are. And then we have our support systems. So we all have our family, our peer networks, other support systems out there that we reach out to. When we are struggling with something, who do we go to for help? Where's that first line of support that we seek help from? So we have these various support systems. And our healthcare and healthcare choices and our life moves through these different systems, and they interact with each other. So next slide, please. I'm going to come back to this point. Let's talk a little bit again. So this slide here, I talk about military help seeking. I want us also, so yes, some of these external structures like concern over career impacts. This is a type of barrier to help seeking we hear over and over again from service members. But that concern doesn't go away when you leave the service necessarily, the military service necessarily. It may be more salient in a military active duty context, but oftentimes people feel concerns over career impacts of admitting they have mental health even when they're not in the military. Likewise, difficulty scheduling appointments and getting leave to attend clinical visits. These are structural barriers that can get in the way of people feeling like they're able to go to a doctor, go to a mental health counselor on a weekly basis. Can I figure out a recurring time in my busy schedule to get to the counselor? Can I get the leave from my work to go to visits that most openings are available during the work hours, and those openings out of work hours tend to be booked months in advance. So how do we get leave to attend our clinical visits and take care of our health? And availability and accessibility to services. So this is a huge one for rural communities. This gets talked about a lot, right? So there's provider shortages in rural areas. The distance to get to those services can be really immense. And so these make it less likely that somebody is going to try to access services. Now, why am I talking so much about this? Well, we all, when we're bringing together our teams to do suicide prevention, right? We have all these great programs and services that we know exist in our town. And as we bring our coalition together, we have all these resources and all these services that we start learning about and start sharing how we can work together. But we still have to ask the question of whether anybody's going to be able to use these services. So we might be able to coordinate our services better, but what if the people in our community still don't use them? So we have to ask about what these barriers are and how we work to overcome them. So in addition to these structural barriers, we also have social and cultural processes. A few ones that come up in a service member and veteran context are stoicism and self-reliance. I can take care of it myself. And treatment discouraging beliefs or stigmas, right? I would be seen as weak. Members of my unit would have less confidence in me. People would make fun of me. These kind of social cultural processes are actually, these are barriers that are embedded within military culture. They are not just embedded in military culture, though. There is an important intersection of cultures that's really prevalent in a military and veteran context. These are also values that are highly associated with masculine culture in our country. And about 90% of service members and veterans are male. And so the military culture, even if you have a female service member, that individual is inculcated in a very masculine culture. Likewise, these same cultural processes are really prevalent in rural culture. We talk about these a lot in rural communities. And more service members per capita the majority come from urban areas, but it's more per capita are rural. So again, there's a preponderance of men and rural individuals in military and veteran populations. These cultures that they bring into the military have a very strong impact on what becomes military culture, which then has a strong impact lifelong on our veterans and their families too. So we have these structural barriers and these cultural processes that serve as limiting factors on whether somebody's going to use the services that you have in your community and are offering. Next slide. So this slide has a lot on it, but there's a couple really quick lessons that we're going to talk about here, because this is where we start getting into, so what do we do about all of those barriers to help seeking that you just mentioned? So first of all, we have the social context in which a person resides, and that's where we get some of these structural barriers from. But an individual, that middle box that's labeled disability and illness career, this is what we talk about as whether a person enters or exits treatment for any kind of health issue. So this can apply to mental health, this can apply to cardiovascular disease, this can apply to disability, etc., physical or mental disability. And so the idea here is people enter and exit services for their health challenges based really on two systems and how they interact with two systems and how these two systems interact with each other. One is the treatment system and the other is the social support system. So the treatment system, these are all these resources and services that we have in a community. And it's things like how much is available, how closely related are the services to each other? Do they provide for what I need today, or is what I need not included in the treatment system? And how well do the services work together and with each other? And so if there's a strong treatment system with a lot of coordination and comprehensive services, then you're more likely to be able to get individuals into the system and keep them in the system, because that system will work together in an effective fashion to make sure that people are funneled into those services that are right for them. But if that treatment system doesn't have the right services or is scattered and not coordinated, a person, when they start at some point in the treatment system, is more likely to exit and not come back to treatment because they didn't get their needs met when they first tried to get in. Likewise, whether a person even goes and accesses services is really influenced by their social support system. And again, when we talk about their social support system, we want to talk about the structure of that network. Like, how big is your social support system? How strong is it tied together? How cohesive of a message do people in that system provide to you? What are their beliefs? Do your friends and family think that you need to get help or not? Because if they don't think you need help, you're not probably going to go seek help if you're being told you don't need it. Do they hold stigmatizing beliefs in your social support system? And what kind of functions do they play? So even if you had the best social support system imaginable for encouraging you to get into treatment for mental health challenges or suicidality, if you don't think of that support system as somebody that you rely on for advice for your health, then it doesn't matter, right? So it's all of these things around the structure, the content, and the function of both the social support system and the treatment system are really what encourage a person to enter services and stay in services. Next slide, please. So what I was just talking about all above comes into this idea of what we call the network episode of help seeking. And so this boils down in a much simpler fashion what I just said on that previous slide, which is you are likely to enter mental health treatment based upon what your peer and family support system tells you, and you are likely to exit it based on those beliefs too. So if you start treatment because somebody encouraged you to, but then you go out with your friends and they start poo-pooing it and telling you, you don't need that, you're stronger than that, you're probably going to drop out of treatment. So when we want to address these barriers to help seeking, it's really important that we not just fix the structural systems, those treatment systems, and what's available and how coordinated they are, but we really also need to work very closely to address the peer and family support systems of service members and veterans to get those systems working in a way that is knowledgeable of what's available and encouraging of treatment. Another important point here is this idea that your social network's structure really influences your health behaviors. So it's not just all about attitudes. So the way that this plays out is, and your outcomes. So if you have a social support system that is really holds positive values towards treatment, research has shown time and again, people who have that type of social support system have better health and better health outcomes long-term from the services. Conversely, if you have a social support system that doesn't encourage help seeking, there's research that has shown definitively that those individuals have poorer health outcomes. So ultimately, this social support system is really important to the actual final health outcome we're seeking to address, in this case, suicide risk and suicidal behaviors. So I want to pause here because I just sort of laid out a lot of dense material and thinking around barriers to help seeking and suicide prevention. I want to see if there's any questions before I go on to talk about rural communities and how it might look more concretely to address these issues. Are there any specific questions, Donna, or that I can address related to those slides above?
Out in terms of the actual outreach that people are doing. If you look at the top of the chat, those were questions that came in from some individuals, and I'm not sure if you're able to see them, but you're completely welcome to begin to address those. But the spirit of them seemed to be that people are in different rural communities and they're hoping to hear about lessons learned for how to integrate that into their outreach and help seeking work with individuals.
Yes, absolutely. And I am certainly going to talk actually about all of these in the next part of the presentation. But let's talk a moment about COVID-19. One of the questions was, we are concerned about service members, veterans, and families in rural area and how geographic isolation and culture has further complicated suicide prevention in COVID-19 times. Any strategies or lessons learned? So one of the lessons learned that you'll see as I move forward in my presentation and talk about together with veterans, that goes right back to what I was just talking about, is this important role of the peer network and the social support system. This has been something we've seen really important in these times of social isolation. And so, for example, in one of our communities that where we're doing this rural suicide prevention program, we've structured the program to really be veteran-led. So it's peer-to-peer. And when social isolation started happening, we asked exactly this question of our current community leads, and they shared some really interesting ideas of how they have tried to address this. So one of our groups has taken the time to sort of put a pause on a lot of their trainings and stuff that they do because that was so in-person oriented, and they've replaced it by sort of identifying veterans in their area that they know might be at risk for increased isolation because of disability or known mental health challenges or a geographic isolation. And they've taken sort of it upon themselves to keep track of who they know, at least within the veteran network, that might be at risk right now. And they're doing wellness checks and reach out by phone and email and internet to sort of keep everybody feeling like they're still being watched out and being engaged. And so this kind of reaching out and checking in on people is something we can still do in COVID-19 times, so to say, and is really something very natural for a peer support system to do, and very powerful if somebody who's not your provider, but is somebody you recognize as a peer or friend reaches out to you to check on you and see if they can help get you connected to anything that you might need help with. So that's one way we've been able to address isolation.
Thanks a lot, Nate, for that, because it has come up, and it came up yesterday. It's come up numerous times from this group that moving forward, people are really aware that there are going to need to be some new strategies that we put in place for how we implement best practices. And so you're speaking about peer support and how to make connections happen and do that outreach as a team, and using folks with non-traditional roles as well as folks that might be in the community like family, friends, or other veterans. I mean, it's all good help. I think that there were some questions that just came to me about, so people are clear, the questions that came in so far are actually in the chat. We have requests for a Q&A for materials. Everyone gets the slides, and if you want the audio and the slides and want to be really sure we have your email, you're welcome to re-add that. It's hard sometimes doing virtual work for all of us. This session is an example. I get the privilege, Nate, of talking to you and letting you hear my voice, but when you start to get 100 people on the phone, it's hard to unmute everyone. So I see there was another question just entered, and I don't know, Nate, if you feel comfortable, addressing them, or if you need to have me read them to you, or how do you want to proceed?
Yes, so this question, I can see it. So the question is, what I discovered is VSOs that are listed as restaurants or bars could not open, so hundreds of veterans lost their safe place. I was made aware of this issue in May. I'm the chair of the state SMVF subcommittee. I pushed the issue up the chain, and within 24 hours, the governor came up with a solution to open all VSOs. This is great. I mean, that's an example of how the social isolation laws to prevent spread of COVID-19 could have an unintended consequence on veterans who rely on these not just as restaurants or bars, but as a critical place of social connection and connection to resources. So it's important that we think about how we can keep these veteran serving resources available to veterans and fix those laws. I really like this example. Thank you for sharing that. Another thing I want to share from Together with Veterans as I start to transition into the next set of slides is, you might say, oh, it's great to, encourage peer connection and one-on-one, but what does it take to get there? And one of the things that we've found over the years is one of the most critical sort of pieces of training that we provide to our veteran community partners is leadership training. And we have actually relied on some very senior retired veterans who are experts in leadership from the military, who have been doing leadership training in the military for their entire careers, and now are retired and in the veteran community, and they're able to come in and support us and really help veterans who are interested to advance their leadership skills that they started building in the military and start learning about how do they apply these leadership skills in their community. If you're part of your HOA board or on the city council or school board or part of a suicide prevention coalition, how can you grow yourself as a leader? And that skill of leadership and how you apply your leadership is really what leads to a group of veterans like the one I was talking about being able to say, okay, we need to shift gears and we're going to start doing this. They have that confidence and skill and social capital built up and those leadership skills to pull it off, to figure out how to find veterans who are isolated and reach out to them. And so leadership skills and leadership training, I think, is a really important way that we can help peer networks solve their own challenges around social isolation, as well as to troubleshoot what's going on in their community as a result of COVID-19.
Well, thank you, Nate, and thank you, Shireen, for entering that idea earlier. And that's really the energy that we're going to need here, because it does seem as though we're pioneers on this issue. We're learning as we go, and everyone knows that it's going to be important for us to really not expect people to come into traditional settings and be able to access services, and that there will be some barriers and that there's going to need to be some creativity on all our parts. So thank you. Nate, do you want to continue now? And then folks, please feel free to keep entering in your questions and we'll take them one by one.
So let's talk about rural communities a little bit, and this is going to get into addressing some of the other questions that were entered in the chat box. So as you can see, and I mentioned already, there are about 24% of all veterans live in rural areas. That's in contrast to 18% and falling of the general population living in rural areas. We see a similar number in terms of how many people enter military service. So more per capita, service members are more likely to come from rural communities and more likely to return to and live in rural communities. Some of the things that we know about this that is structurally important to keep in mind is rural veterans earn less money per year than those in urban areas. They are more likely to live in poverty. They are more likely to be older. They are more likely to be male, although there is still a significant population of female rural veterans. They also, because of the age and disability status and income, they're also more likely to be enrolled in the VA, and yet there aren't as robust of VA services in rural communities at the same time. And so there are challenges to access to care that they face that we're constantly trying to address. Next slide, please. So workforce shortages in healthcare and behavioral health. About 85% of all rural communities in the United States have a behavioral health workforce shortage. So we know there's a substantial population of veterans in rural areas. We also know, unfortunately, that veterans in rural areas die by suicide at about 20% rate higher than urban veterans, even after we control for distance to care and different demographic factors. Another challenge, though, is in addition to that, the primary care providers who end up becoming a critical source of behavioral health care in rural communities. Surveys of primary providers in our country show that they report being less prepared and less confident to deal with suicidality and less likely to screen for it because they don't know what to do. So our primary care providers need support and training in rural areas to better serve the behavioral health needs of their area. As a result of all of this, rural residents are less likely to receive the mental health or substance use treatment that they may need compared to urban residents. And yet, it's important to mention that rural residents do not have higher rates of depression and mental illness necessarily than urban residents. They don't have higher rates of substance use. They do not have higher rates of depression. But they do have a higher burden from the depression or substance use or other mental health challenges that they experience. And this is largely likely related to the lack of resources and the less specialty care and less access to best practices in mental health care in rural areas. And so this depression in a rural resident is more likely to cause serious disruptions in that person's life long term than in an urban area. So next slide, please. It's also really critical for us to not just focus on the negative in rural areas, right? So there are a lot of things that make rural places strong places to live and protected places, not just causing health problems. First of all, a few facts about rural places. As I've mentioned many times, more veterans per capita. And there's also this culture of ingenuity, hardiness, and adaptation. So you actually have in rural areas potentially a higher proportion of resilient role models and veterans who can serve in that way of being successful or resilient role models to veterans who are struggling, or veterans who are transitioning back into their local community, or to National Guard members and reserve members who live there, for example. And then also, the culture in rural communities is not just about self-reliance. Yes, there is this stoicism and this idea of I can solve it and I can sort of be strong and et cetera. But there's also a simultaneously, there's this dynamic or this like push and pull between that culture and a culture of we band together, we help each other. And so you can tap into that culture of local support. People want to support each other, and people lean on each other in unique ways in rural communities while also feeling a strong sense of self-reliance. Another interesting piece of this is that people in rural communities tend to have more social capital. What we mean by this is that the smaller of a community that you live in, it's the more likely that you're going to know the decision maker. You're going to know the chief of mental health for the hospital. You're going to know the CEO of the bank. You're going to know the mayor, the sheriff, or at least you know somebody who knows that person. So there's this incredible network of being able to get to decision makers very easily that we can tap into. And again, so if we teach leadership skills, veterans can learn to access and use this incredible social capital they have by standing up and providing leadership in their community. It's also therefore important, though, because rural communities don't always trust outsiders, that insiders must lead. So we need to make sure with rural communities that we're helping bolster those leadership skills within the community, because if we rely only on external leaders, we're not going to be trusted. So we come to this idea by veterans and for veterans with the mission of strengthening protective factors, enhancing community supports, and sort of troubleshooting the healthcare system to figure out how we can strengthen it. Next slide, please. So this is the Together with Veterans program that I'm going to transition to talk about now. We took those ideas I just talked about and said, well, what do we turn this into concretely? Well, it's this idea that we can take empowered veteran leaders, leadership again, and put them together with the community system and the community service partners and coordinate action and planning with the leadership from veterans. So it starts with veteran consent and leadership and incorporates that community system to collaborate together to reach out broadly, both through the social support system and the treatment support system. Next slide, please. I'm gonna, back up please, I just see a question came in. How does it work if some family are encouraging therapy but friends discourage? That's exactly, I mentioned that earlier. So this is why what we say is we belong to these different communities and these different networks. We have our friends, we have our family. So one of the big questions that it comes down to answer that is, who does the individual rely on for advice? So if they go to their family for advice in that situation, they're more likely to seek out treatment. But if they're, and even if they have those treatment discouraging friends, but they don't see that network as important to this part of their life, they won't listen to them necessarily. So you have to sort of, you know, there's a contradiction there that people live with, and sometimes it leads to people leaving treatment. It really comes down to which network do you rely on more for treatment seeking advice. So, you know, the only real solution is this idea of tackling both. We really need to figure out how we can take the community of veterans and their families and get and change the culture within them broadly to promote and support help seeking, so that both the family and the peer network are encouraging help seeking.
Thanks for bringing that up, Nate, because there were some questions about safety planning and how to integrate families and friends and other veterans, especially in COVID times, and helping to check in on people and be sure that they are attentive to some of the signs of changes and doing the plans that they've established. That kind of integrating them and making them part of the whole process from the get-go, that's very helpful. Thank you.
And one thing that can be a good way to think about that, like, so if you're a clinician and you're doing a safety plan, you obviously need consent from your client to share it with anyone else, right? But before you say, can we share this with your family, and jump to this idea that you need to get this with the family and get the family on board with it, it might be important for you to try to understand which social support system is most important to that individual when it comes to their health care decisions. And see if you can then engage someone from that network in the safety planning process, not just the family, because it might not be the family. They might not look to their spouse or their parents for healthcare advice. They might look to their battle buddies. They might look to somebody who lives thousands of miles away with, but they serve with. They might look to somebody they meet at the VFW on a daily or weekly basis. And so think about that. Think about understanding who are those critical network supports that individual relies on, and see if you can't figure out how to incorporate them into the safety planning more explicitly.
How about the language, Nate? Jesse there has a question about whether we should be thinking about health seeking and health versus help. But it has come up even as this public health crisis has happened with the pandemic, that people, in terms of self-care and even mitigating risk, are very open when it comes to physical health. But the idea of this help, again, is that vulnerable piece that you mentioned before.
Yeah. Right, and I think that that's a good point about help seeking might not be a culturally agreeable term, especially in a context of strong self-reliance and masculine culture that I was describing earlier. Somebody might not want to seek help, but they might want to improve their health. And so if we can turn that language into more of an empowering type of language, this isn't about you getting help. This is about you improving your health for yourself. That could be a very powerful way to overcome some of the stigma and barriers around culture and help seeking or health seeking. Next slide, please. Okay, so now I'm going to move on a little bit into some concrete examples of what Together with Veterans implements in terms of suicide prevention strategies. So within the VA and through the Governor's Challenge, you may have seen these 3 strategic focus areas. Together with Veterans also promotes these 3 strategic focus areas of identifying service members, veterans, and families, and screening for risk, promoting connectedness and improving care transitions, and increasing lethal means safety and safety planning. Now, Together with Veterans takes those focus areas and has 6 concrete strategies that we work on in communities. First, we provide suicide prevention training, so gatekeeper training throughout the community as a way of increasing the community's ability to identify someone at risk. And we particularly promote gatekeeper trainings that have a military and veteran cultural component to them. So it's really about identifying service members, veterans, and their families who might be at risk in the broader community. And then we also provide education and training and outreach to primary care providers to encourage universal screening both for service, history of military service, and for suicide risk, and also to support them in understanding how to build their referral systems and networks. For lethal means safety and safety planning, we definitely work on promote lethal means safety and enhance behavioral health suicide prevention. There was a question earlier about, this can be really challenging. So promoting lethal means safety can be really challenging, especially in rural communities. Yes, absolutely. We have found that if I go into northern Montana somewhere and try to talk about firearms and suicide, they're not going to listen to me, and I'm just going to get pushback. If, however, firearms owners, and in particular veterans and advocates of firearms and gun ownership rights, are talking about firearms and suicide prevention and safe storage of firearms, that message is more likely to land well. And so that's where in our program we really lean on this idea of veteran leadership and local veterans leading the messaging in their community. So we provide training and information, but it's really a process of helping our local rural veterans see and learn what they need to do and what conversations they need to have within their peer network about firearms safe storage in a time of suicide risk. We've had some innovative solutions come out of that. We've had in one community, an American Legion post decided that was run by a firearms dealer. He owned both a gun shop and was the head of this American Legion post. He put gun lockers into their post in a locked room. And then with the idea that we'll all get training in gatekeeper training, and if we see one of our fellow service members at risk, we can say, hey, why don't you come down to the post? Don't give me. Why don't you come down to the post and store your gun here for a while until you're feeling better? But this gun is still in your possession. You have the lock to the locker. What was interesting about this is it kept the firearm in legal possession of the veteran, but the locker was in a locked room. And so to get to your locker, you still had to interact with somebody from the American Legion Post leadership who could further act as a gatekeeper before you would access your firearm. So it created a lot of layers and time and place between access to the firearm. So there are innovative solutions. That wasn't an idea I came up with. That was an idea that a local veteran leader in a rural community came up with. I can't speak to how well it's working, but it's a solution that he thinks works in his very, very small remote area. So again, the message has to come from the peer, from the veteran, from the firearm owner. If we're going to be talking about firearm safe storage and you want that message to land well, that's the strongest place for it to come from. The middle area is what I want to talk about today more, the strategies of promoting connectedness and help seeking and improving communications across veteran serving programs. So if we think back to what I talked about in terms of these social support and treatment support systems, this is how, together with veterans, is directly trying to tackle those two networks to work synergistically together to offer protection and promote health and well-being among veterans. Next slide, please. So the social support network. We want to strengthen veteran peer and family networks and change the social norms within those networks to promote health, or I love the idea of health seeking from within the network. So to do this, next slide. Who do veterans trust? I feel like I'm beating a dead horse a bit here, but these are direct quotes from some of our qualitative research with rural veterans. We would rather do it from boots on the ground and work up because it's better to have brother to brother than to have a stranger. Local peer-to-peer ground up is better. I don't know veterans in crisis in the state or the region, but I dang sure know veterans in crisis in my community. It's just us. So they trust each other and they know who each other are. And they know who within their network is somebody that they have to keep an eye on. So this is where, if we're going to promote connectedness and promote help seeking from within the social network, we need to identify, train, and equip those natural leaders in the veteran community to be even stronger leaders, to know how to interact and assess suicide risk, and to refer individuals to care effectively. But we can also lean on them not just from a gatekeeping perspective, but also from a public awareness campaign perspective. So I mentioned lethal means. This picture right here is of a group of veterans from northwestern Montana who are all strong gun rights advocates and firearms owners, and they told us in the beginning that there was no way in hell we were going to talk about firearms and suicide. The first thing they chose to do after they got through 8 months of needs assessment and action planning and wrapping their mind around suicide prevention, the first action they chose to take was to go to a gun show and talk about firearms and suicide. So it is very possible to break through this cultural barrier of firearms ownership in rural communities if you allow the community to lead from within. Next slide. On the other side is the treatment network. Remember, so we can have the best social support system, we can have great public awareness campaigns from peers and families and changing social norms there. But what about how well veteran serving programs and services actually work together? Do they work together? Who knows how they work together? Who knows what they are? So we have to address those questions. And together with veterans, we have an explicit process that we work with communities to figure out what are all the veteran serving programs in my area and who's working with who and what services do they provide and how do people access those services, and then getting them all together and dialogue with each other so that their network among veteran serving programs is strengthened and the referral systems are strengthened and warm handoffs are strengthened. So next slide speaks to this a little bit. It's about network coordination. And so this is a network map in one rural community where the big blue box in the center is Together with Veterans. It's the local Veterans Coalition that's running this project. And after 2 years of doing this project, they're the biggest and most central organization for keeping all the veteran services organized and coordinated. But interestingly, whereas I don't have the year one data on here, but that big white box in the center used to be split up into 2 boxes and not as central. And that box right there is the local community health center. And they, over years of collaborating with the veterans, they've been able to become more cohesive and also become an important hub that works closely with the veterans. So you can see that through veteran-led action, we actually end up with what, if I showed you the previous map, you'd it's chaotic. It's a lot more lines. So in a sense, it looks more dense, but it's a lot less organized. So you have a really nice organized with a lot of eras. You don't have anyone who's really super isolated in here. Most of the veteran services are connected in some way to the mental health center or the Veterans Coalition. So next slide. And this is from the leader of that Veterans Coalition, whose network map I just shared with you. And what he said about how they got there is we built upon individual knowledge and connections to bring awareness and issues beyond the organizations traditionally responsible for addressing them. So this, again, it was a veteran-led action to bring everybody together, and they just got all the different organizations together to start working better like spokes on a wagon wheel, so that the coalition is the hub for veteran suicide prevention, but all of these organizations that were doing their own thing are now thinking about how they're working together, at least when it comes to veteran services. So those are the goals of where we're trying to head with changing the social support system and the treatment support system. Next slide, please. I think I'm getting close to being, yeah, that was my last slide. So I'm happy to address some of the questions that come up and just engage in general discussion. Thank you.
Thank you very much, Nate. And I see a couple of questions that I think we should, I see a couple that are similar theme, and it has to do with training, really. So in the network work that you do, how do you go about training families, clergy, friends, partners? You know, how do you train them to prepare them to be able to be helpful in terms of decreasing risk and identifying service members and veterans that need additional help and being that bridge?
Yeah, so there's a couple layers to that question. So I guess maybe I should just sort of like walk you concretely through the Together with Veterans process of how we get from A to Z, or A to training, and then what that training looks like. The first thing we do, once a community has been identified by stakeholders as being a good potential fit with a lot of veterans and high suicide rates, but also some identifiable leaders that can take this on, that have the capacity to do this. First thing we do is we work with a champion or two in that community to organize what we consider a recruitment meeting, where we meet only with veterans in the community. Oftentimes sometimes that meeting is just one meeting, and we get a big group of 30, 50 veterans from around the area, and we present to them about what they have in store for them if they go down this route of working with us on this project. And then they get to say yes or no. They say, yeah, come on in, work with us, or not. Sometimes that first meeting is 2 or 3 people, and we have to go back again and go back again until we get a large group and what appears to be a broader consensus of veterans in the area who say, yes, we want this to happen here. So we actually search, number 1, for leaders, and number 2, for some evidence of broad consensus that they even want to pursue this project as a veteran-led suicide prevention initiative. You know, we don't get no. Veterans who tend to want to do this. So it's not that we ever get a no, but we have run into communities where they want to do it, but they just can't figure out how to organize to get it done. And so we continue to work with them and encourage them and try to bring them along to that organizational capacity level. But then we have this steering committee that is created, that it has to be 50% veterans or more. And we provide a lot of training for them in a lot of different facets. So one of the first things we do is we give them gatekeeper training. So we provide the VA SAVE training. We provide potentially, we will find out with their help what kind of suicide prevention training resources exist in the community. So in one community, they got QPR training, in another community, ASSIST training, in another community, Columbia screening training. So we make sure that the leadership team itself is sort of becoming a sieve for trainings. They're getting a lot of different suicide prevention trainings. And we teach them about what public health is and how to do a public health suicide prevention program. We teach them about the 3 strategic focus areas and the 6 strategies we want them to plan and implement. We teach them how to conduct a community needs assessment and how to use their community data for action planning. We teach them how to develop a structured action plan that is effective and that that is simple enough and concrete enough that they can follow piece by piece and have success and track their success. And we teach them over and over again about leadership. We teach them facilitation skills and we teach leadership skills. So we want this leadership group to have all these leadership skills. We want this group to have 2 layers to it too. We want it to be a core group that is the decision makers, but we want them to have a bigger steering committee within of community partners of maybe 20, 30 different agencies at the table. And so we walk them through a systematic process of gaining the skills, building their community partnerships, and everybody being on the same page with what this program is. And then they plan and implement their plan of how to address the question you just asked. So I don't do that. My team doesn't address the question that was just asked about training family members and clergy and peers. What we address is training the leadership group within the community to make those decisions of how they're going to pull it off, what they're going to focus on, what they're going to do. In one community, they chose to get 26 veterans to become master QPR trainers and start training QPR all over their area. In another community, they worked closely with the Behavioral Health Center, the mental health center, which provided assist and safe talk training to recruit people to those trainings on a regular basis. And in another community, they've worked primarily with the VA to offer VA-based trainings to different constituencies. But again, in all of those communities, they come up with their plan of which audiences within the community we need to reach out to and train. And what we do is we provide support to them on how to plan effectively and implement their plan.
Another related question is there guidance and ongoing supervision? And you know, there was a question related to that. Is there an availability of this model, or how would people reach out together with veterans to be able to access some help bringing some model like this to their own community?
Yes, so there's 2 ways. There's 2 primary paths right now, so together with veterans specifically. First of all, I guess I will get our moderators our program website, and they can send it out to everyone here. I realize it should be on this last slide, and for some reason it's not there. But we have a website for our program, and that website, you can download the toolkit that will walk you step by step through the Together with Veterans process. And you could just take it and try to implement it for yourself. We also have a sort of a secondary website that takes that toolkit and turns it into actually an online toolkit. So you can get to all of that from our main program website. You can also learn about who's out there doing this project, who are the communities that are currently active, and reach out for sort of consultation directly with, like if you're in Montana, there are 2 different Together with Veteran groups there. And you could reach out to them and find out what they're doing and if there's any way that they can help you or you can help them. So you can see we have active sites in Colorado, Montana, Arizona, Texas, North Carolina, Virginia, and we have new sites starting up in New Hampshire, Pennsylvania, and Michigan. In addition to that, we are actively recruiting more sites right now. We have funding for a total of 22 to 36. That's a big range, but just bear with me that there is this big of a range. 22 to 36. We're shooting to try to launch around 22 new communities in the next 2 years, and we've only recruited 3 of those new communities so far. And so there are plenty, we need partners. We're looking for partners. We want to roll this out more broadly. So if you are in a state that has a rural area of high need, reach out to me and I can start the process of connecting you up with our recruitment team and start that dialogue going. We're really keen on addressing areas of highest need. So areas where there are high suicide rates and high veteran populations in rural America are a priority. So would love to talk to you more about sites that we currently have going and how you can interact with them, or whether you'd be interested, whether your state or area would be interested in starting it together with Veterans Site.
Thank you. Shireen was basically talking a little bit in the chat box there about doing crisis intercept mapping, looking at the crisis system, and having people with lived experience, veterans and military families join the community partners to expand the capital there and the capacity. And so I don't know if you have any suggestions about that piece, but they're looking to replicate that across the state, that type of a model where veterans and family members are part of the team that actually implements the next step for outreach.
Absolutely. It's so a group of professionals can sit down and try to do the crisis intercept mapping, but it's always going to be more meaningful if you can get somebody with lived experience helping understand what walking through that system is like. So we as service providers might know how we're linked, but does that mean that we understand how our clients move through the services we have? No. So what you're describing here of having veterans and their family members as a critical part of that discussion is really, I think, important to making those crisis mapping processes more effective, and also ensuring that you're simultaneously addressing not just the treatment system there, but that peer network, and understanding how that peer and family system interacts with the treatment system.
Thank you. I don't see any other questions in the box at the moment that we didn't cover. We've really pretty much, in even a loose way, with your presentation, especially those beginning questions. I guess there was one question about some of the characteristics of rural populations in terms of service members and veterans, and some of the assets and strengths that brings for recovery and resiliency.
Okay, I guess I can talk a little bit more about some of what we know in terms of suicide risk and protection in rural communities. My research team, we just actually completed a systematic review of this question exactly. And the short answer is that the biggest risk factor for suicide death in rural communities is ownership of firearms. That is the most strongly related factor to why rural communities in the United States experience higher suicide rates. So if you want to address suicide in rural communities, you have to talk about firearms. And you have to figure out how to have those difficult conversations and how to get trusted insiders who can speak with authority about firearms in their community to lead that discussion. Secondly, the other another big area of risk was substance use, especially among men and especially among Native American populations. So among rural men and among rural Native American populations, substance use was a predictive, quantifiable risk factor for higher suicide rates. So access to alcohol, access to drugs, drug use rates, DUI rates, those kind of factors. So in the rural context, substance use actually is more predictive of higher suicide rates than it is in urban areas. So that doesn't mean it's causal, but there's a strong interrelation between substance abuse and suicide in rural communities, stronger than that relation is in urban areas, actually. And then, of course, the third big factor is access to care. We talk about this a lot. The challenge is that it's hard to figure out from the literature what the problem is exactly, and which factor around access to care leads to higher suicide risk. There's just so many different ways that it's been studied, and so many different factors, whether it's this, are the services available? Is there a culture and stigma that is serving as a barrier to access? Are the services that are available higher quality? All those things I've discussed before show up as risk factors related to suicide in rural communities. So those are the big things, I would say, when you're talking about suicide risk in rural communities: firearms, substance abuse, and access to care. And so thinking through how to address those, how they're interrelated, is part of the challenge that you have to work with in rural areas. In terms of the protective factors, it comes back to a lot of what I was saying in terms of insiders and trust in the rural communities. So actually, we have these sociocultural barriers, but we have an advantage too, which is this large pool of social capital and trusted leaders inside rural communities. So it really, really is important to lean into that in rural areas and ensure that rural communities feel like they have mastery and control over the program in their area, that this isn't a state thing, that this is their thing, and that they own the problem and they own the solution locally. That's really critical to being, I think, successful in implementing and making change happen in rural areas. And then, that because that all leans into those factors I mentioned around social capital and resilience and hardiness. So if you can figure out how to encourage local rural leadership, you're tapping into those rural protective factors around adaptation and hardiness and social capital, and that's going to make the program more successful. Question just popped up about transportation. Yes, transportation is a challenge, and it's good for program. It's really hard for rural communities on their own to address transportation. So this is a great, I think you said that the question is, how are states helping? I would say that this is an area where states can really step up and try to figure out, is there a way that they can provide state level funding for transportation services? Because rural communities on their own are going to struggle with this at many times. So what are things that states can really help rural communities with directly have to do with financial resources. So how can we help rural communities have transportation programs? How can we help boost housing shortages in rural areas? How can we increase access to care through telemedicine or rural provider training programs? So if we do doctor residencies and psychological internships where there are placements in rural areas, those kinds of things are going to increase the amount of people who finish their training and choose to live in rural areas. So those are the types of state level policy issues and ways you can address some of those structural barriers for rural communities.
Thank you. That's really helpful. There was a question, Doug Carver mentioned the church has traditionally been a hub in rural communities, and yet you haven't talked about their role as much in this call, and how significant that is, especially when it comes to guilt, shame, moral injury, and various practices. Are you able to comment on that?
Yeah, absolutely. So I guess the reason I haven't talked as directly about it here is that it goes back to our projects model, which is really about the local leadership making decisions about how they build their community and network and who to pull in. we absolutely talk to them as we're teaching them and working with them on this building of their network. We talk to them about what are the critical sectors of the community that they should consider engaging. And so faith is at the top of our list, along with the first responder and the healthcare communities. Those are three sectors of the community that's sort of like at the top of our list of what we teach rural veteran teams to look at and focus on. It can be really challenging for them to engage with faith leaders in some of our communities because we found a mixed bag. And so we always try to, and oftentimes what we'll find is one or maybe two leaders or congregations join the initiative, but that doesn't mean they all do. One of the challenges is the stigma, especially in certain religious groups. So if they're not joining the network directly, there's the second layer that we work with on is who are you going to provide suicide prevention training to? And we encourage them to include in their action plan reaching out to the broader faith-based community to do suicide prevention trainings and using whatever partners they have from faith-based organizations to help do that outreach.
That's helpful. And so a last question that I see here is just basically talking about safe storage and the challenges that happen. And this is in Montana from Jackie Lloyd Randolphi, working on educating as best they can about safe storage in the Native community. I'm sorry, I read that too quickly, talking about how suicide deaths are through hanging with tribes, and there's issues with things like that being harder to talk about than safe storage in general. Yeah. Any tips for that?
Yes. So in the veteran community at large, firearms are the number one means used, and they're the most lethal. In rural communities, that factor is even larger, so firearms are even a bigger factor. But then I think, you shifted over into Native American communities, and the numbers and the makeup of choices of lethal means changes when we jump culture like that. So yes, hanging is more prevalent in Native American communities, and firearms are actually used less, even though the suicide rates are higher in Native American communities. You still need to talk about firearms in those communities, but it does start to become more of a question of, the way I would think about it is sort of to put your investigative surveillance hat on and just start asking the community first, what are the most common ways that people are dying by suicide? And what are some possible solutions to that? So a good example related to hanging with this approach is that a colleague of mine worked up in Inuit Canada in Nunavut, and he was working, this was about 20 years ago, he was working with a community up there and, started off by asking that question, what is the problem? Instead of assuming that as a suicide prevention expert, he knew how to prevent suicide in this rural Inuit community, it started with asking them what they thought the solution was. And they said, well, everybody who dies by suicide here uses the exact same method. They hang themselves from the curtain rod. And so what we want to do is remove all the curtain rods from the community. And they removed all the curtain rods from the community, and for 5 years, there were 0 suicide deaths. And so it's really, to flip the question, it's really more about trying to figure out what the biggest problem is lethal means wise in any given community and troubleshooting with them possible solutions to it. So that's what I would recommend, especially with working with Native American communities. So one thing, can you share specific data related to firearms and veterans and rural? Yes. I can email you a ton of data. Off the top of my head, I'm going to sort of say that it goes from like 60-some% among urban veterans up to 70% among rural veterans in terms of firearms use. So all veteran firearms use, I think, is 60-some% of all veteran deaths by suicide involve a firearm, and it's pushing 70% plus for veterans in rural areas, if I'm not mistaken. I do need to check on that, so please don't quote me, but I can get you a lot more data on this. I can get you, if you would like, I could share studies and numbers on more broadly rural American suicide deaths and suicide too.
You know, I do want to mention, Nate, if you make that available to us, if people have requests such as that, you just let us know in the chat box, and we'll specifically make sure you get what you asked for. The TA Center is here to serve you, and we work with excellent presenters and subject matter experts like Nate, who are just dedicated to this and can really be gems when it comes to helping to provide what you need for your work. I was looking at Lindy White's comment here, and it brought to my mind that there are presenters, but there's also the community of learners we've got here. And Lindy was commenting on appreciating the language issue, but there were also some other folks who discussed, the verbiage. And she offered, from the National Guard's perspective, the CR2C, Commander Ready and Resilient Council work on holistic health approaches. And if anyone's interested, she'd be happy to discuss or share. So let us know, and we'll set up opportunities for connection and help you all to connect if you don't do that directly with her. But, these are the gems that help us all to partner with each other and on a national level work together to try to create the momentum that's needed. So thank you. I think we're coming to the close, Nate. There seem to be questions that came that were in certain areas and certain, I smiled because they were both in the chat box as well as the question Q&A, and I bounced back and forth and tried to get them all. We will go through this, and if there's anything we missed, make sure people get their answers. The slides and the audio are available to everyone. We'll automatically send them out, but if you had some issue around your registration, just let us have your email. And on that end, I understand that some folks were delayed signing on because of an Adobe Connect mix-up and address, so I just want to say thank you for your hanging in there and staying engaged and joining, and appreciate the challenge that you had getting on. And all of us, I guess, this isn't an easy time, but people care about this topic, and we're all spending our best time making it as strong as possible. So don't hold back. Let us know how we can make this better. And thank you all for your attendance. Nate, do you have any closing words?
Just want to thank you all for the hard work that you're doing as part of the Governors and Mayors Challenge and partnering with the VA on suicide prevention for service members, veterans, and their families. And look forward to working with you. Feel free to reach out to me with any questions. My email is on this slide, and look forward to continuing to work with you. Thank you.
Thank you, Nate. And I do want to see the next couple of slides. We have some upcoming events that should be featured. Next slide. We do have the dates down here, July 13th and July 20th. We have kind of this really interesting two-part web-based virtual session. It's on safety planning, and it's been amazing, the wonderful mobile app that the VA has put together. And the National Center for PTSD is going to provide an overview of some of their mobile apps, because we know that some of the technologies and tools and resources that are available now are going to be even more important than ever for the work we have to do remotely with clients and folks and our families and friends. And so this is going to help everyone find out about the free app that's tied with safety planning. So do try to take advantage of it, because other resources and toolkits will be discussed as well. But if you can't make both, feel free to make one in either one. The second session that's related takes a deeper dive into safety planning and really the practice guidelines and how safety planning can be used by not only providers and clinicians, but supported by families, friends, and veterans in the community. So we're really blessed to have Dr. Pearl McGee-Vincent do the first session, and Lily Mells do the second, both experts from the VA. And the next slide is going to be another event that's coming. We've had a lot of folks say, okay, I'm getting screening, but what happens after screening? How does assessment fit in? So what we have is Dr. Matarazzo, who's going to, from the VA again, she's Director of Clinical Services there and works, I guess, with you too, Nate, some. We're so lucky to have her strength and knowledge. She's going to really take a dive into the best practices and how to implement the tools and resources for screening. And she's going to help everyone to see what can be done in terms of screening and risk assessment. And she's going to link it in with, you know, what it means to be making decisions about deeper evaluations that people need. So we hope you can attend that one as well. We have about 4 more coming out, and these flyers will be coming to all of you on this list, but you can always check in with the TA Center. Some folks were asking about how to garner, you know, support for informing decision makers and policy makers and their governors and their mayors and their county health people about the impact and nature of the problem of veteran suicide issues and military family issues. So we're going to feature something on that. And there was also an upcoming event that's just about how to do more nitty-gritty, you know, best practices in suicide prevention in COVID times, because we know we need to be looking ahead knowing that this is going to require our creativity for some time. So there'll be a lot of tips and lessons learned about doing that effectively as well, so that we continue to really not, you know, lose sight of what matters and really continue with our suicide prevention work. So those are a couple of things. We're going to wrap up. I'm going to, again, thank you very much on behalf of SAMHSA and the VA and the SMVF TA Center team. And I really hope that you'll all email, text, and let us know you want more of, less of, what your wishes are. And thank you for your time again. Okay, we're going to wrap it up. Bye-bye, everyone. Thank you, Nate.